Morning. Myself, Dr. Krishna. Today I'm going to present with a persistent diagnostic challenge managing an evolving case of optic neuritis. So, aim to report a fascinating case of unilateral optic neuritis in a young male that continues to pose diagnostic dilemmas, showcase the complexities in its diagnosis, analyzing differential diagnosis of optic neuritis, highlighting the need to distinguish demyelinating, autoimmune, infectious, ischemic, and nutritional causes for accurate diagnosis and treatment. So here comes a 18-year-old male with a complaints of a sudden onset unilateral domination in left eye for past 4 days after awakening up in the morning. So systemic and past history was not significant. Family history was not significant. Personal history was he was a vegetarian by diet. So on ocular examination, right eye was examination points were within normal limit. In the left eye, visual activity showed 6/24 with pinhole not improving. Color vision was defective. Contrast sensitivity was defective, and extraocular late agnexa conjunctiva was within normal limit. So cornea anterior chamber was within normal. People showed left eye RPD grade 2. Lens was clear. So on fundus examination, right eye showed within normal limit, and the left eye showed blurring of optic disc nasal margin with a hemorrhage spot on nasal to the optic disc. Macula and rest fundus was within normal limit. So perimetry showed right eye within normal limits, and the left eye inferior alternate defect was seen. So in fundus fluorescence, it showed the right eye retinal circulation within normal in right eye, and whereas in the left eye, it showed disc leakage in the late phase. So the MRI brain orbit 2 optic nerve showed bulky retrobulbar and intraorbital segment of left optic nerve with still hyperintense signal and mild enhancement suggestive of left optic neuritis. VEP showed right eye with normal P10 latency, and left eye showed increased P100 latency. So for this patient, multidisciplinary approach was made and the neurological consultation made. All investigation like CSF lumbar puncture was done, include AFB fasting and CBNAT, India, fluid cytology, KOH culture was negative. Systemic infection and autoimmune workup was done like ANA, ANCA, VDR was negative. All tests was negative, including serum and MOG antibody test was negative. So what we found is in this patient, oligoclonal bands was absent in both in serum as well as CSF, and low serum B12 levels were seen. Increased serum immunoglobulins levels more than 2100. So here comes the differential diagnosis. So demyelinating optic neuritis, MS-related optic neuritis, whatever the points in favor was. He was a young patient, and the MRI showed hyperintensity with enhancement, and VP showed a delayed P100. So points was against was oligoclonal bands were negative in serum as well as CSF. Alternate defect was no ischemic and no MS brain, multiple sclerosis brain lesions was there, no pain and ointment. So it could be the most probable list. So next comes to the neuromyelitis optic spectrum disorder. So points was favor was severe optic neuritis was possible, raised immunoglobulin versus. So the points were against was it was only unilateral, no myelitis or systemic features, and aquaporin channels were negative. So it could be possible. So emerging antibody associated optic neuritis was point was famous disc swelling with hemorrhage, bulky optic neuritis on MRI. So typical approach is point was against like antibodies were negative, and it is usually bilateral. So probable maybe. So ischemic optic neuropathy point was favors the altitude defect was seen, disc blurring with hemorrhage was seen. So against was like MRI showed enhancement and VAP showed latency. In AON, the amplitude will be decreased and latency will be normal and less likely diagnosis. Infectious optic neuritis like TB, syphilis, HSV, Lyme, Bartonella. Pine was famous like it can mimic optic neuritis, and discriminant was also present, raised immunoglobulin was also present. But against was has no systemic features or MRI, and MRI was showing demyelinating features. So less likely to be normal. Our nutritional and toxic optic neuropathy, like he was a vegetarian by diet, so low serum B12 was seen, possible it could be a B12 deficiency toxins. But typically, this vitamin B12 shows bilateral symmetric, so unlikely to be diagnosis. So on further course, this patient was planned to start intravenous methylprednisolone. So, but on second day of admission, spontaneous improved vision was noted. With resolution of fundus changes, patient was kept on follow-up and given vitamin B12 injections. At first month follow-up, visual activator 6/6 pustules with a mild red saturation. So discussion, this case of unilateral optic neuritis with acute vision loss, optic disc blurring and inferior alternate defect was pose diagnostic challenge due to overlapping features with various optic neuropathies. MRI confirmed left optic neuritis and VEP showed increased P under latency, while elevated serum hemoglobin is a result of underlying autoimmune process. Differentiating demyelinating like multiple sclerosis and NMOSD, MOG optic neuritis, autoimmune ischemic and nutritional causes was crucial to guide treatment. And a structured stepwise diagnostic approach integrating clinical imaging laboratory findings is essential for accurate diagnosis and optimal management. So here comes the conclusion. This case has highlights complexity of diagnosis of optic neuritis and the need for a thorough multidisciplinary discipline approach to understand its diversity in etiology and facilitating a more effective management strategies. Accurately diagnosing optic neuritis requires distinction between demyelinating autoimmune ischemic infectious and nutrial causes, crucial to prevent mismanagement and optimal outcomes. These are my references. Thank you.